Let's go through the warm-up review. The first question has an image. 2 drops of drug X are instilled into a patient's left eye. In the dark, both pupils are dilated. In the light, which is on the bottom image, the right pupil becomes miotic while the left pupil remains mydriatic. So what is drug X? Well, there are 2 classes of drugs that could do this. It's either going to be a sympathetic agonist like epinephrine, which would cause mydriasis, or it's an anticholinergic drug, an antimuscarinic like atropine. But since they don't make epinephrine eye drops, it's probably atropine or some other antimuscarinic. And the last one, what's the antidote for poisoning with each of the following? So the antidote for copper poisoning is penicillamine, remember copper pennies. The antidotes for mercury poisoning are dimercaprol and also succimer. The antidote for TPA and streptokinase is aminocaproic acid. And for digoxin, the specific antidote is anti-digoxin antibody fragments. But remember, the main treatment for dig toxicity is to stop the digoxin. You're going to give potassium and magnesium as needed, and then treat any arrhythmias with atropine or lidocaine, depending on whether it's bradycardia or tachycardia. Now let's go ahead and get started with the lecture.
I am empty. I am nothing.
End of systole.
The door slams in my face.
Closure of the aortic valve.
I must rest, regain my strength.
Isovolumetric relaxation.
Oh, but now the door is open.
Opening of the mitral valve.
I am renewed. I'm filling with life.
Filling of the left ventricle.
Oh, I'm bursting. This is too much. Shut the door, shut the door.
Closure of the mitral valve.
Confined. I feel the pressure building within me.
Isovolumetric contraction.
I must burst forth against the barriers of this world.
Opening of the aortic valve.
Share all that's within me. Pour out every last drop.
Systolic ejection.
I am empty. I'm nothing.
End of systole.
The door slams in my face.
Closure of the aortic valve.
I must rest, regain my strength.
Hello everyone and welcome to our Step 1 video on the cardiac cycle. Today is exciting because we're going to be talking about graphs, but not just any old graphs. Today we're looking at the cardiac cycle. Now this is a 5-star topic. You can expect to have at least a couple questions about this on your test. So we're going to start by looking at the pressure-volume loop. And this pressure-volume loop is looking at both the pressure and the volume, strangely enough, that is present in the left ventricle during both diastole and systole. So a complete cardiac cycle or just one heartbeat. Now, as you can see, pressure is on the y-axis and volume is on the x-axis. And again, this is referring to pressure and volume in the left ventricle only here. So where should we start? We should start on this loop. We should go to the diastole part. So diastole is going to be beginning with the closing of the aortic valve. And you find this at the left upper corner of this loop. Now at this point, the ventricle has just finished its contraction and expelled a whole bunch of blood. Now the pressure is initially pretty high in the ventricle because of that contraction, but after the aortic valve closes, the pressure drops dramatically. And you'll notice that the volume is not changing at this time. The line is going straight down. No blood is entering or leaving the left ventricle at this time. This is called isovolumetric relaxation. And as the name implies, the ventricle is relaxing and no blood is entering or leaving. Next, we move to the bottom left corner. Now, when the pressure in the ventricle drops below the pressure in the left atrium, something happens. Because the pressure in the left atrium is greater than that pressure in the left ventricle, the mitral valve is then forced open. And when the mitral valve opens, you have blood moving from the left atrium into the left ventricle. Now, the ventricle is still not contracting yet. Right now, all we are seeing is passive filling. And at this stage, I think of the ventricle as a very pliant, underfilled balloon. And even though there's an increase in volume, we don't see much of an increase in pressure. So the line here is still pretty flat. Now you may see loops in other books or other resources where that line is maybe sloped up more just a little bit, and that's fine, but realize that the pressure is not increasing much here. You do have an atrial contraction at the end, which completes the filling of the ventricle. And then the mitral valve is going to close. Now we see this at the bottom right of the circuit. And that completes diastole. Now the left ventricle is full of blood and all the valves are closed and the pressure in the left ventricle is still very low. And now that mitral valve is closed, now we can actually begin systole. So at the beginning of systole, you have what's called the isovolumetric contraction period. It's called isovolumetric because, again, we're not changing the volume, but the pressure is increasing at this point. During isovolumetric contraction, both the mitral and the aortic valves are closed. Pressure is increasing because the ventricle is now contracting. And then all of a sudden, the aortic valve opens. This is in the right upper corner of the loop. Blood rushes out of the ventricle. So what causes the aortic valve to open? Well, it opens when the pressure in the ventricle is going to exceed the pressure that's in the aorta. So when the ventricle overcomes that aortic pressure, blood is able to escape the heart. And as you can see by the graph, when the aortic valve opens, the volume of blood decreases because it's leaving the heart, but the pressure is going to continue to increase in that ventricle because of a continued contraction of that ventricle. Then after the ventricle contracts and a significant percentage of the blood has been expelled from the ventricle, then the aortic valve closes. And that signals the end of systole. And then we start all over again with diastole and that isovolumetric relaxation again. So next, let's move on to some pressure volume loop variation. So we saw what the normal loop looks like. Now let's see what happens to that loop when we alter things like afterload, like contractility, and like preload. So first, let's remind ourselves what the normal loop looks like again. We see all the different phases here, not too difficult. So then what happens when you increase afterload? This loop has a very different appearance. Why do we see this loop getting very tall and very skinny? Well, an increased afterload means you have more pressure exerted back on the heart. So think of that as an increased aortic pressure. So the pressure in the ventricle will need to increase even further before that aortic valve can open and then let all the blood out. So the ventricle has to work harder to overcome that increased aortic pressure. Otherwise, the aortic valve will never open. And luckily for us, our ventricles are really strong, and they have the ability to produce a stronger contraction. And with that stronger contraction, the aortic valve opens at the top right corner here, just like in our normal loop, except it's at a higher pressure now. Now, when the aortic valve opens, then you start to lose volume. But you've utilized so much contraction power during that process to overcome that aortic pressure that the volume that you're able to expel from the ventricle is then decreased. So the heart just doesn't have enough contraction power to get as much volume out of the ventricle before the aortic valve closes again. So that's why the loop is skinnier. Now that means that the stroke volume is decreased. Remember that stroke volume is the difference between the end diastolic volume and the end systolic volume. And because the ventricle was unable to eject its usual volume of blood, the left ventricle is then left with an increased end systolic volume. So the left ventricle never empties as well as it should. So that's what you see with increased afterload. So remember that increased ventricular pressure is needed to overcome that aortic afterload pressure, and the stroke volume is then therefore decreased. Next, what happens when we increase preload? Well, when you increase your preload, you're putting more blood into the ventricle from the atria. And that's why the graph moves further to the right. There is more volume in this left ventricle now. Most of the time when you put more volume in the ventricle, the heart is actually able to expel more blood without actually changing the amount of pressure that you're generating. So as you can see, you do not need more pressure for the aortic valve to open. Now, after the aortic valve opens, the heart is able to expel that extra blood in addition to the usual stroke volume, and you're left with a normal end systolic volume. So increasing the preload allows you to increase your stroke volume simply because you're putting more volume in that ventricle, not because you've changed the contractility at all. Now, the end diastolic volume has increased, but the end systolic volume is unchanged. Now, what happens when you increase contractility? Well, by increasing contractility, you will achieve higher pressures in the ventricle. The ventricle is squeezing harder. The afterload, again, is the same, and the preload is the same. The aortic valve is still going to open at its normal pressure point because the aortic pressure, or that afterload, hasn't changed at all. Now, because we have more contractility, the heart is able to eject more blood out of the heart. So we see an increase in stroke volume and a larger ejection fraction. And we see a decrease in the end systolic volume. There's less blood left in that ventricle. But the end diastolic volume is still going to be unchanged. The left ventricle is still able to fill up to its usual capacity. Now, an easy, maybe sort of dumb way to remember how the PV loops change with each parameter. So if we have increased afterload, you would write the letter A. And the letter A is kind of a tall and skinny thing. So you can kind of imagine that's how that pressure loop looks, like a tall, skinny A. And then if you have increased contractility, you can write the letter C, and you make that kind of curve to the left. So it kind of tells you that it's going to move that curve over to the left. And then you have the increased preload. So when you write a P, the curve of the P, letter P, is going to move you to the right. So that's kind of an easy, cheap way of remembering which direction these curves are going to move whenever you change those right there. Okay, so let's look at another diagram. And yes, I know this has a lot of stuff on it, but it's actually pretty useful, not that hard, and you do need to know it. Pressure here is on the y-axis, time is on the x-axis. Pay special attention to where systole and diastole are taking place, and use what we just learned about that cardiac cycle to kind of orient yourself to when these events are taking place. Now there are many lines here. Each of these lines represents a different area or a different measurement regarding the heart. So the very top dotted line here is your aortic pressure. The first section is systole. Well, what happens first in systole? Well, we just learned that we have isovolumetric contraction and then the aortic valve opens. So when that aortic valve opens, it's opening because the pressure of the ventricle starts to exceed that of the aorta. And you can see that right here. The orange line is the left ventricular pressure, and right here where these two lines intersect is where that aortic valve is forced open. Now there is a rapid ejection taking place from the ventricle into the aorta at this time. Now, that's why you see an increase in that pressure. Now, then the pressure is going to decrease, and then that aortic valve is going to close. Now, after the aortic valve closes, you have an abrupt, kind of mild increase in pressure again. The dip here is called the dicrotic notch, and that brief increase in pressure is referred to as the dicrotic wave. So what's going on here? Why is the pressure increasing in the aorta after the aortic valve closes? Well, as the ventricles enter into diastole, there is actually a brief reversal of flow from the aorta back into the left ventricle. And this helps aortic valves to actually shut. This will also result in a slight increase in aortic pressure caused by the elastic recoil of the semilunar valves and the aorta. So the dicrotic notch and that second increase in the aortic pressure is due to that elasticity of the aorta. Now there's another important event occurring at this time period as well. Here we see the filling of the coronary arteries. Yes, the coronary arteries are filling during diastole, not during systole. Now this backflow of blood back towards the aortic valve is the blood that is actually going to fill those coronary arteries. The coronary arteries open right behind those aortic valve leaflets, and so that allows for filling of the coronary arteries. Next, let's go over the left ventricular pressure. So we talked about this a little bit already. This is the orange line, and it's pretty self-explanatory. We went through the cardiac cycle with the pressure volume loops. And you can see the dramatic increase in pressure during isovolumetric contraction, and then a continued increase in pressure even after that aortic valve opens, and then a rapid decrease in pressure during isovolumetric relaxation, and then relatively low pressures during diastole. Now it's obviously up during systole and at baseline during diastole. You do see a little increase in pressure just before the beginning of systole, and this is due to atrial contraction. So as that atria contract to get that last little bit of blood into that ventricle, we do see a small increase in pressure just before the close of the mitral valve. Next, let's look at the left atrial pressure or the venous pulse. These are not exactly the same, but their waves will be very similar. Now, on some images, you might actually see these separated. On this image, they are actually combined. So let's start at diastole on this one. The pressure in the atrium is pretty flat throughout most of diastole. And as we just saw with the ventricle, we see an increase in atrial pressure during that atrial contraction. And this is sometimes referred to as the A wave. Usually we refer to the A wave on the jugular pulse. But then we see another spike in pressure during isovolumetric contraction. This is called the C wave. So this pressure is actually coming from the ventricles. So when the ventricle contracts, the pressure will actually cause the mitral or the tricuspid valve to kind of bulge into the atria, and that causes an increase in pressure in the atrium. And then we see one more wave called the V wave, and this is an increase in atrial pressure due to filling against a closed mitral or tricuspid valve. Now let's talk about your heart sounds next. So your heart sounds are definitely worth knowing and very testable and high yield as well. So let's start with your S1 heart sound. So you see your S1 heart sound, it's going to correspond to mitral and tricuspid valve closure. S2 occurs right with the aortic and the pulmonic valve closure. So those are easy. Now we get to some hard ones. And then there's an S3 heart sound. So what is the S3 heart sound? Well, the S3 heart sound is in early, kind of to mid diastole during rapid ventricular filling. And it's associated with increased filling pressures and is more common in dilated ventricles. So when you think of S3, think of rapid ventricular filling. And what specifically can cause that S3 heart sound, because not everyone's going to have one, let's go through a few of these things. So remember that we said that this is associated with dilated ventricles. So what dilates a ventricle? Well, this can occur with dilated cardiomyopathy, congestive heart failure, mitral regurgitation, and a left to right shunt. So what is that left to right shunt? Think about things like a VSD, an ASD, or a PDA. So those are the few scenarios where we can actually have that S3 heart sound. Now just to reiterate, dilated cardiomyopathy, CHF, mitral regurg, left to right shunting, including that VSD, ASD, or PDA. And that S3 can be normal in children. It can also be normal in pregnant women. So in these situations, you see a lot of preload, a lot of filling pressures there, but you also want to think pathologically with dilated hearts. Now let's move on to your S4. Your S4 heart sound should be right before your S1 heart sound, and your S4 heart sound is your atrial kick. It occurs in late diastole, and this is due to high atrial pressure associated with ventricular hypertrophy. So the left atrium, when it contracts, it must push against a very stiff left ventricle wall. So when you think of an S4 heart sound, think of stiffened left ventricle wall in that atrial kick. Now, when do you have a stiffened left ventricle? Well, you would see it during hypertrophic cardiomyopathy. You could see it during aortic stenosis and just chronic hypertension with left ventricular hypertrophy. In chronic hypertension, the left ventricle has to hypertrophy to overcome that huge afterload. And then also commonly after an MI, you might hear an S4 heart sound in that situation as well. So just to reiterate, hypertrophic cardiomyopathy, aortic stenosis, chronic hypertension with left ventricular hypertrophy, and after an MI, those are the major scenarios where you're going to see an S4 heart sound. All right, so now let's look at our ECG stuff. So the QRS segment is associated with atrioventricular valve, or the mitral and tricuspid valve closure. And that's just going to make sense there. Now, what does your QRS segment represent? Well, it represents ventricular contraction. So it represents that electrical signal going through the ventricle. So as the ventricles contract, they build up pressure, and that's what's causing the tricuspid and mitral valves to close. So your QRS segment is associated with that AV, atrioventricular, or the mitral and tricuspid valve closure. Now let's move on to splitting. We're talking about splitting of S2. So the splitting of S2 can actually be normal, especially in younger individuals and also especially in athletically trained individuals. Now, normal splitting of S2 happens with inspiration. So why does this happen? What's going on here? So the S2 is split here because your aortic valve closes earlier than your pulmonic valve. Now, much of the time, the closure of these two valves is happening so closely together that it sounds like one heart sound. It sounds like just the S2 heart sound. But as you inspire, those two closures can spread apart. So you might hear two brief heart sounds of the split S2. So why does this happen? Well, as your diaphragm lowers, you decrease the intrathoracic pressure, and when the atmospheric pressure exceeds intrathoracic pressure, air goes into your lungs. That's how we breathe. Well, the same thing happens in the vasculature. So as your diaphragm goes down, you decrease intrathoracic pressure, which causes that air to go in the lungs, but it also causes more blood to actually come into the right atrium. So inspiring causes more blood to go into the right atrium. Therefore, more blood in the right atrium is going to mean more preload, and that's going to go into the right ventricle. Well, because there's more volume in the right ventricle, it takes a little bit longer for that right ventricle to squeeze out all that extra blood, and it takes a little bit longer to close the pulmonic valve. So the right ventricle has to get rid of more volume than the left ventricle. Now, also, as the right ventricle fills with more volume, the interventricular septum gets maybe a little bit pushed over to the left slightly. So not only are you increasing the amount of blood in the right ventricle, you're maybe slightly decreasing the amount of blood in the left ventricle. So all that leads to the aortic valve closing a little before the pulmonic valve, and you get that split. Now, wide splitting of the S2 is an exacerbation of what we just described. Wide splitting of S2 is associated with pulmonic stenosis or a right bundle branch block. So these are areas where it's going to take even longer for the right ventricle to expel its volume. It's not just with inspiration here that you have this wide splitting. It can also be with expiration as well. So a split S2 on expiration is never normal. Split S2 on inspiration can be normal. Next, let's talk about fixed splitting. So this is associated with atrial septal defects. So again, what's going on? Where do you have high pressures, on the left side of the heart or the right side of your heart? Well, most of your higher pressures are going to be on the left side of your heart. So with an atrial septal defect, the left atrium is spilling blood into the right atrium. So more blood or preload is going into that right side of the heart. And now there's an overloading of that right ventricle again. So again, this will lead to a slower closure of the pulmonic valve and a fixed splitting of the S2. So it's during inspiration and expiration again. And then next we have paradoxical splitting. This occurs when there is a delay in the emptying of the left ventricle. We've been talking about right this whole time. Now let's talk about the left. So instead of the aortic valve closing slightly before the pulmonic valve, now the pulmonic valve is closing first because of this delay in the closing of the aortic valve. And paradoxical splitting is associated with aortic stenosis or left bundle branch block. So how does this splitting change with inspiration? Well, in our previous types of splitting, the splitting would actually worsen with inspiration. But within paradoxical splitting, the aortic valve closure and the pulmonic valve closures are actually getting closer together because the pulmonic valve is delayed slightly due to that increase in blood going into that right side of the heart, as usual. So that's why it's called paradoxical splitting, because the splitting seems to improve with inspiration. All right, guys, that brings us to the end of the lecture part. I know that was a lot. Let's go through our end of session quiz. First question, when does isovolumetric contraction take place? Well, it's going to take place during the QRS, so after the mitral valve closes, but before the aortic valve opens. Next, how does an increase in afterload affect the stroke volume of the heart, assuming contractility remains the same? So it's going to decrease the stroke volume. Remember, it's making our pressure volume loop taller and skinnier, like the letter A. Next, what impact does an increase in contractility have on stroke volume, assuming preload and afterload remain constant? So this will increase the stroke volume. Remember, it's shifting that curve to the left, like the letter C going to the left on that pressure volume loop. Next, what heart sound is associated with dilated congestive heart failure? So dilated ventricles, that's going to make you think of an S3 heart sound. Next, what heart sound is associated with chronic hypertension and a stiffened left ventricle? Remember, that stiffened left ventricle should make you think of an S4 heart sound. And what give rise to the jugular venous A, C, and V waves? So remember, A is the atrial contraction, C wave is the ventricular contraction, and then the V wave is an atrial filling against a closed tricuspid valve. Next question, where does the QRS complex fall in relation to valvular dynamics? Well, basically it's right before mitral and tricuspid valve closure, because it's the electrical signal of the QRS complex that causes the ventricles to contract, and that increased pressure in the ventricles will cause these valves to close. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.